I want to start by thanking everyone for including me here today, and thank you to all the organizers who made this happen. It's a big effort, but it's worth it, and so thank you guys. Like she said, my name's Lindsay. I'm a clinical research coordinator, and for anyone who doesn't know what that is, it can mean a lot of different things to a lot of people, but my interpretation of it is I'm a liaison. I'm a connection. I'm a connection between patient advocacy groups, the doctors and the scientists and the specialists in this field, and families and researchers, and we try to just bring us all together so we can improve outcomes for all the families with Smith-Kingsmore syndrome and other rare disorders. So we've seen lots of slides like this, so I'm going to hand wave several of these slides just so you guys have access to them later in the data. But we know that Smith-Kingsmore syndrome is in response to a mutation in the mTOR pathway. And what happens when this pathway is dysregulated? So too high or too low signaling is not good. And so what we want is an even signal. And if there's too much, there's cell overgrowth causing macrocephaly, overly excitable networks that might be associated with things like seizures, sleep disturbances, and learning differences. And those are the things that we want to target and try to help focus on to improve for our patients. So research questions. What am I doing here? What are we looking at? So we want to try to understand the full spectrum of the symptoms that we see in Smith-Kingsmore syndrome. What families say that they do is you go in, you get this diagnosis, and the first thing the genetic counselor says is, don't go home and Google, you're going to freak yourself out. First thing every family admits is, didn't even get out of the room, and I Googled it, and I freaked myself out. There's a spectrum. There's a whole spectrum. There's some severe phenotypes or characteristics. There's less severe. And there's buckets of seizures. Am I going to get those? Sleep disturbances. Are we going to get those? We don't know yet, and we're trying to learn that. So we can go into the office and say, all right, you have this variant. We expect you guys might have some seizures, so we're going to get you some EEGs and some other testing to make sure we can catch those early, and here are the best opportunities that we can see for those. You don't have to worry about sleep disturbance. So like, don't freak yourself out over hearing about those things. We want to give you guys those paths so you can get to the right interventions at the right time and not feel like you're overwhelmed having to go to every single thing that might hit every single problem that might come up. So that's what we're looking at. Why does this matter? Improve the quality of life of the families that we see, the patients that we have. We collect natural history data. It's essential. Getting parent reports is essential to help to inform that prognosis, exactly what I was saying, help the guidance that we get from our geneticists and our genetic counselors and our specialists that we see. And then also we've heard a lot of talk this weekend about clinical trials. Are we going to have one? Is there one coming? Natural history studies like this one inform the clinical trials. We need to understand what the foundation looks like before we can say, here, let's treat this. We don't know what dose works. We don't know which type of drug works, if it's even a drug that would be the target, if it's a genetic therapy. We need to know what the natural history of Smith-Kingsmore syndrome looks like so we can build up and look at targeted therapies. So the approach to this study, we started in 2019 with the inaugural meeting with Smith-Kingsmore syndrome. And then we've collected data up through this past year. We're still ongoing, so this says through 2025. If you'd be interested, our data improves with the more participants we have. So reach out to me, we're ongoing. We have no plans of stopping enrollment. So let me know if you want to be interested in enrolled because we have a lot of data here. It's mostly just trends right now. We're getting some insights of whether variants are important. We have some insights on what to expect with longevity and with age. So is there something that's more common in young kids or in older kids? We're seeing trends. This data is still preliminary. We've got a great big cohort, but the more data we get, the more we can fine tune that into groups, and we'll talk about that as well. So what did we look at? We looked at genetic reports and MRIs and EEGs, clinical testing, clinical notes from your geneticist, your neurologist, people that you see in clinic. We also had a lot of parent-reported outcomes. We have surveys, and those of you who are enrolled in our study, you guys know I send out a lot of surveys. I'm sorry, but I really value your opinion. And you guys have been the most responsive cohort of participants and community that we've had. And so I want to say thank you. And the data we have is because of those responses and everything you have. So thank you very much for those. Here's what our cohort looks like. And to my awareness and from the chart reviews I've done, this is the largest cohort of research participants we've had. So I'll just hand wave over the slide, but we've got about almost 20 females, about 30 males, 49 participants. And because we have such a large cohort, like I said, we can break it down and look, instead of just doing trends of there's this average number of people that have these conditions or symptoms, we can break it down into groups. So a lot of our slides will break down the same data into age groups, preschool, school age, and adult, as well as variant size. So here's a map that you guys have seen about, these are the participants that we have and the variants that we have included for the research participants we have in our group. And the average of the symptoms that we've seen from chart reviews and parent response, as you've seen, we've seen these from many people already. We know what the common disorders are, the common symptoms that we see: developmental delay, motor delay, macrocephaly, autism spectrum symptoms, things like that. We'll talk about that more in depth. So other things we looked at, this is another slide I'm going to hand wave a little bit. We looked at MRI and brain imaging. We saw that we had about, brain MRI is something that's clinically suggested for most kiddos with SKS. So we had a lot of those reports. Most of them had brain abnormality seen, about 79–80%, ventricular megaly, as well as problems with the corpus callosum and the frontal lobe. So frontal lobe is associated with things like behavior, emotion, executive functioning, planning, and things like that. We also looked at EEG findings, and we saw that there's seizures in some of our participants, but not all of them. We want to look at why. But about 26% showed evidence of seizures in the clinical EEG reports that we looked at. So I'll point out that that 26% is lower than some of the reports we've seen in some of the literature, and we'll talk about a little bit of that, and Dr. Kruger will explain that a little bit more as well. So here's where we start taking some of that data that we found, and we break it down into a couple different ways to look at it. The first way I'd like to look at it is with the gene variants. So a lot of people come in and they say, all right, well, I have this variant. What's that mean? Again, these are trends. The more participants we have, the more concrete this data will be, and the more we'll know definitively, yes, you can worry about this, or you should get testing for that, and you can sleep well knowing that you don't have to worry about this particular thing. So when it comes to delays, developmental delay, speech delay, learning disabilities, those are highly prevalent. So about 92% in most of those domains. But I wanted to point out, for developmental delay, the FAT-C domain is associated with only 67% of participants responded saying that they had that occurrence. So maybe we might see a trend that people with a variant in the FAT-C domain might not have to worry about developmental delay as strongly as other kiddos with any of the other variants. Same thing with the heat domain and speech delay. A lower percentage reported that being a concern. Again, still just trends, but motor development, motor impairment, fine and gross motor skills. Most participants said that there was a delay or a problem with that, but the kinase domain was only about 50%, so that was 20% difference between the other domains. So maybe if you have a variant in the kinase domain, you might not have to worry as much about motor problems. Looking at other problems and things like that, abnormal EEGs, regression, and tics, much lower in the FAT, the FRB, and the kinase domain than there were in the heat domain and other variants. So again, these are all trends. More participants, more data, the more we can statistically say these ones are the ones that might be associated with these characteristics, or those are the others. So if you want to enroll, come on and join me, and we'll improve the quality of this data. So then we took the same data set, and instead of looking at the variants, we looked at the age groups. So a lot of families come in and say, okay, well, my kiddo's in preschool. What can I expect? Are these things gonna, the symptoms that they have, are they gonna get worse as they get older? Are they gonna get better? Are they gonna develop new symptoms? So some of the things we've seen, things that are early onset and then last throughout the lifetime with things like macrocephaly, motor impairment, fine gross motor skills, gait or walking, balance, coordination abnormalities, and seizures. If they see them in preschool, they're likely going to last through grade school as well into adulthood. And then neurodevelopmental features such as developmental delay, speech delay. Again, if we see those, we tend to see those early, and then they stay with the kiddo throughout life. Divergences that we see, things that might increase with age, things like regression, tics, autism, aggression towards others, and self-aggression. Those are things that we don't see as highly reported in our preschool cohorts as we see as the kiddos age. This might be new onset of symptoms. It might be recognition of symptoms that were there that we didn't identify before, or just communication. So we don't know if it's identification or if it's a new onset symptom, but we see that it's not reported in preschool age, but it's more prevalent in the adult groups. And then there's some interesting characteristics that we see that are more prevalent in school-age children than there are in preschool or adults, things like developmental delay and learning disability. Again, we don't know the cause yet. We don't know, is it identified because they're being assessed more thoroughly. They're in school being compared directly to their peers. Is it less common as families age, as the kiddos age and turn into adulthood because they've come up with coping strategies? I'm able to seek out the behaviors and the careers and the lifestyle that is easiest for me to move forward. I've figured out ways to work around these and therapies to cope with the symptoms and to learn to adapt. We don't know if it's improvement or if it's just we've learned our ways around these, so this isn't a concern that we're reporting anymore. Okay, so here we get into some of our validated surveys that we've done. We've done an ADHD assessment, we've done behavior and emotional assessments, and the development trajectory as well. So these are busy slides. I'm just going to hand wave a lot of them, but give you some of the take-home messages. So attention, inattention, hyperactivity is rated by the ADHD scale. Higher scores are worse. So you see that with age, the preschool group usually has lower scores on both the inattention and hyperactivity, but we get towards the clinically significant over 90%, the 90th percentile in the adults. And so we look for worsening symptoms of inattention and hyperactivity as we increase in age. So looking for ways to approach that. And we know that our kids are getting older. Maybe we try to teach them coping mechanisms for inattention and focus, and try to look for therapies that'll improve their ability to focus in a school setting, for example, or as they develop into adult years. Okay, so the Nicenter is a behavior rated form. And so there's both the positive behaviors and negative behaviors. The first two panels are the calm, compliant and calm, and the adaptive social. Those are the higher, better, positive social. So a score, the lower scores are worse, and if they get higher than the trajectory line that we have there, that means that they're a good score. They're more in the neurotypical range. We notice that all the kids we have are below that clinically standard line for the positive behavioral ratings of being compliant and calm and adaptive and social. So transitions are hard. Being able to stay calm when they're upset is difficult. So we recognize that we want to help put together some interventions that will help adapt to those problems. So for the other subscales that we have, the conduct problems, insecurity and being anxious, hyperactivity, self-injury, and stereotypical behaviors, and other things. The line marks the lower ones, or the higher ones are worse traits. So you want to be below the line if you want it to be a neurotypical phenotype, neurotypical characteristics. So you'll see that the compliant calm, they don't quite reach clinically, they are not reaching clinically normal behavior. And then for self-injury and stereotypical behavior, so they're self-injuring, that is both above the line for clinical significance, but also it shows a statistical significance for that blue line that it's increasing with age, and so that the kids in preschool are not showing those phenotypes and those characteristics as much as the adults. So the Vineland is another behavior scale, and it looks at things like communication. Can they talk? Can they receive communication? Can they write? Daily living skills. Can they take care of themselves? Are they okay to get dressed? Can they be motivated to get themselves dressed? Can they do buttons and zippers and things like that? Can they feed themselves? And then socialization, having motivation to interact in the world with other people. And the Vineland, the important take home is not can they if they had to, can they if I reminded them and told them, it's will they, and that's the difference. Will your kid get up in the morning and pick out their clothes, get themselves dressed, make their bed, brush their teeth, get themselves breakfast? No. Neurotypical or SKS, will they? No. Can they? Maybe, but that's not what we're assessing. And so when you guys are answering these questions, I want to make sure that we have that really clear. Can they? Maybe. Will they? That's a difference. So So on here, the lower scores are the greater impairment, and we see here with the SKS population, the trend line, the horizontal line is the line of clinical significance, and everyone's below that. And we'll see things like socialization and communication that it gets worse with age and is statistically significant with the socialization, where the blue trend line shows that there's a very big difference between the preschool socialization and the adults. So we see more isolation as our kiddos get older and transition into adulthood. Okay, so social responsiveness scale. Being social. Sorry, I did this. I was gonna say, you get this. Okay, good. So the social responsiveness scale is being social, interacting, communicating with others. And we'll see that most of the higher scores are greater social impairment. And we'll see that there's only a couple of these subscales that reach the severe scale. So I put in a moderate line for the lower light blue line, and the higher one is the severe. So most of the kiddos range in the moderate clinical significance, but some range into the more severe, like the ones with restricted interest. So if your kid's only interested in talking about a particular thing, they focus on those, they're hyper-focused, and they don't want to talk about anything else, and you try to engage in any other topics. You want to talk about the baseball game you guys are going to go to tomorrow, and they don't care less. This might be a symptom associated with SKS. We also looked at longitudinal comparisons. And so this is a little more parsed out, and this is a really busy slide, so I'm not going to go through piece by piece. But we wanted to look at, I'll also refrain and take a step back and put this back on. You guys are the most responsive community we've had with surveys. A lot of times we've only been able to collect data from other communities like what I've just shown. What are the averages? And maybe we can break it down into ages, trends on variance. We've had 50% of our participants responded longitudinally, which means took the same survey over and over and over again. And I want to say thank you, because we can have some data like this. So the blue bars are showing longitudinal data. That's what we call true longitudinal data. So my kiddo took a scale, and they were in preschool. And then they took the scale again, they were still in the preschool range. They took the scale when we were in a school-age kid between 5 and 18. And they took it again when they're between 5 and 18, and again and again. So that's what the blue ones are. The milestone transitions are the magenta lines. So those are, my kid was in preschool and now they transitioned into the school age. Do we see a difference in these longitudinal scores? Mostly, is there improvement or regression in their symptoms? And is that related to just the score? They're right at this border. Doesn't matter if they're going on to a different scale of measurement or not. So in general, what we're seeing is a lot of the blue lines are below the line. So above the line means positive improvement. Below the line means negative scores, regression, or the first time I took this test and the most recent time I took this test, the score got worse, basically, is what we're looking at. And so we're showing with a lot of these, there's, and any of the scales that aren't showing, those are 0. There was no change. So we're seeing that there was regression in some of the symptoms for within the same age group. And some of them showed improvement when they bumped up from one age group to the next, so from preschool to the school age. So we're not sure if that's a difference in just how it's measured. If you're right at that cusp and you were at the very tippy top of the abilities for preschool age, and then you're at the very bottom. But some things like the SRS scale are showing that maybe they're higher functioning when you get to the next one. So we're still looking at some of that longitudinal data to see if that's showing trends in importance. So we don't know if it's consistent with the age norm and the way the scales are created, or if it is a difference in symptom change. Another question we get a lot, response to interventions. We hear, so we know what gene is mutated. We know we're in the mTOR pathway. We know there's drugs that target the mTOR pathway. Should we take them? Should we not? That's what some of this data that we're collecting is looking at. We've only had 6 respondents say that they were using an mTOR inhibitor, but I want to be transparent and show you what they've said. So first panel is a response to an mTOR inhibitor, and this is just parent response of, did we improve? Did symptoms get worse? All 6 of our respondents said that there was either a short-term improvement or completely resolved symptoms based on what measures were important to the parent. Again, this is just parent reports and just like little comment fields on some of our surveys, so it's not real concrete, and we want to look at that in more depth as we go forward. Perceived benefits included things like attention and focus. That was the most important, most reported improvement. Speech and language, improved motor skills, and things like that. So we're seeing some improvements, and we want to put together some more scales to ask you guys, all right, so what dose were you on? Which exact treatment did you use? And look at more concrete data on what was improved so that we can inform. If we want to do a clinical trial, if we want to suggest off-label use in the future, what's the best route for that? So we don't just start giving drugs to kids, because drugs have side effects sometimes. And we don't want to just use kids as guinea pigs. We want to learn and make the most informed decisions as we're moving towards the future. Side effects we've seen for the families that reported: sleep disturbance. Now, if anyone wants to talk to some families that have been on an mTOR inhibitor, there's titration. Too high, too low is not good. You've got to get the right number. And if you're off even a little bit, you might have days without sleep. And that is not something we want. So we want to make sure that if we approach a clinical trial or off-label therapy use of any kind, we want it to be the right dose. We want to be monitoring the right way, asking the right questions. So other supports people have seen: school supports, IEPs, things that Christine Serbinsky had discussed yesterday, and other options as well. And then there's allied health therapies, talking about social responsiveness and response to stimuli around the environment and things like that. Those things might be helpful, ABA therapies and things like that. And then others have reported cannabinoids and some positive response to those as well. So still just very limited data, and we're planning on improving the data that we have, but we wanted to have those there. So in conclusion, there's some emerging data that we have. We've got some really robust cohorts of information that we want to display to everybody, show you what we know, what we don't know, be really transparent about that, and how we can move forward. So there's behavioral and psychiatric features that evolve early and stay with kiddos throughout life. There's some that show some age trends or some variant trends, and we want to keep an eye on those as well. And then patient-reported outcomes. Those are important. Those are important to help inform our doctors so they can help improve prognosis and recommendations for therapies. But it also helps inform clinical trials and make those as informed and robust as we can possibly have in the future. So we are looking at a lifespan personalized medicine method where we have potential early interventions, sustained neurodevelopmental support, whether that be pharmacological or clinical interventions, or just therapies of other kinds, and then neuropsychiatric treatment later in life, and lifelong monitoring, and multidisciplinary approaches as well. So with that, I want to thank you guys for your time and attention. We couldn't do this without you. So everyone who's seen another survey from me, another email request with my name in the response line, thank you for responding. Your input is valued. We are listening, and we're trying to do the best with the data that you've supplied for us as we possibly can. We've also had great collaborations with the team here at Lurie. They used to be the team at Cincinnati, and then they left us. But we keep our ties because they're the best in the field, and we have some really awesome people with us as well. And so we're using those ties to help improve outcomes for all of the families we work with. So thank you for your attention, and thank you guys so much.